Institute for giving this opportunity to be with you many times. And today we are going to have a discussion or debate on robotic versus laparoscopic incisional hernia repair. Edward Deming has beautifully said, without data, you are just another person with an opinion. And today, in this debate, I am not going to show you any video clipping. I am just going to show you only the numbers so that the numbers speak for us. And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. The outline of my next 12 minutes would be why debate? Why robotics? Which hernias can be done robotically? What is the plane where the mesh has to be placed? Are there any advantages, disadvantages? And what are the complications of robotic or laparoscopy? All of us, even the patients, the surgeons, all of us are concerned about the outcome. Have we been able to give the outcome of recurrence-free hernia repair, be it inguinal, be it incisional, be it ventral? No, not yet. Primary ventral hernia repair has still got the recurrence rate of 5 to 10% at 2 years, and incisional hernia repair still has a range of 25 to 45% at 3 years. So are we in the right direction or not? All of us have seen these era of open surgery. Now you can see that how the open surgery is coming down. Laparoscopy has plateaued, whereas the robotic surgery is going up throughout the world. And again, I say, robot is not the future. It is the present. And the future is now. We started our robotic program way back in March 2012. When we used to do lot of robotic sleeve gastrectomies for super morbid obese patients, and ultimately we had the best possible training from Professor Giulinati and Marsiquet. But we realized that in last 2.5 decades, now you can see the numbers, 38,000 plus reviewed articles and 10,000 installations of robotic throughout the world. And can you imagine, in India also at the moment we have more than 150 installations of even Da Vinci. I'm thankful to my son also, he is working in Da Vinci, but for sharing those slides. And in this one can see that 9,203 robots have already come. And now the era of open surgery, the laparoscopic surgery, the robotic surgery is also gone. Now it is the artificial intelligence surgery. So this is the era 4.0, and one has to see that the thrust at the moment, even all over the world and especially in US, is that you can see the 22% growth has been there in 2023 only. Means so many surgeons are adopting the robotic hernia surgery, and ultimately they are passing on the benefit to the patient. And this was a beautiful article by one of our very close friends, Dr. David Lamento, and he says that robotic platform, what it does and what it does not do in hernia surgery. There has been lot of, I would say, studies. And in this, they have compared the robotic versus laparoscopy, and lot of advantages are there. And many times my opponents would definitely say that where are the randomized control trials now? There are n number of randomized control trials and systematic analysis on the record, in the literature, which definitely prove that laparoscopy has still got the recurrence rate of 13%, whereas the robotic surgery, because of the ease, because of the magnification, because of so many reasons, the recurrence rate has gone down to 4%. And reoperation rate, this is a major difference, I would say, in robotic surgery is of the order of 0%, whereas in laparoscopy it is 11%. Otherwise, yes, I fully agree. In the initial phase, you would take longer time. The cost is higher. Post-operative pain there is no difference. Quality of life is more or less same, but many studies have proved that in robotics at 1 year definitely it is improved. The most important is the surgical site infections and the wound complications are more or less same, but when the surgeon sits on the console and he is able to suture the top, suture the bottom, then it makes a difference. The surgeon is not standing in, and I would say, especially for my younger colleague, is that yes, we are not saying that laparoscopy should not be done. It should be done, but for the complex hernia cases, one has to go in for the advancement and one should take the fullest advantage of the technology. And in this publication also, you would see in robots hernia project 2021, the Moissam had beautifully done 451 case patients, and in this he showed that patients undergoing incisional hernia repair, the portion of lap IPOM surgery has decreased from 52% in 2015 to 14% in 2019. What does that indicate? That the numbers of complex abdominal wall hernias being done laparoscopically are definitely decreasing, and the trend is that robotics, we are able to justify our presence, and ultimately the patient is getting the maximum benefit. What is the ideal plane? Initially, all of us started doing robotic IPOM plus. But we realized that that was not the place, intraperitoneal placement of the mesh was not the ideal one. And now in various studies, it has been seen that if one is able to place in the mesh in the retromuscular space, that definitely has least complications, and these definitely have least recurrences also. So one has to be careful that whether we are doing by laparoscopy or we are doing by robotic method, the mesh has to be retromuscular, retrorectus, then only we'll be able to see the difference. And in last few decades, all of us have seen so many procedures have come. We started with IPOM plus, and then now it is transabdominal retromuscular umbilical prosthetic repair, TAPP. Again, going back to TAPP of inguinal region, but for incisional hernia also robotic TAPP, and then the era of rectus aponeuroplasty. That means you dissect the defect, take the contents down, do the aponeurosis dissection, and then place the mesh in a retromuscular plane rather than intraperitoneal. And after that, ETAP RS. So what I mean to say that if you are not updated, you are outdated. My answer is loud and clear, especially to my younger colleagues. Please do not suffer from excusitis. That the cost is very much, patients cannot afford. No, that is not the answer. Answer is that you should be well versed with the technology. You should be knowing how to do the TAR in those situations in which you are not able to approximate the defects. For example, more than 10 centimeter defect, definitely one needs a TAR. And if we are able to offer these kind of patients the TAR, and that too with a lot of precision, that definitely helps us. And again, most important is, please, for especially to my opponent, I would say, don't think only of the patient. Think of yourself also. You have to carry on operating. Why did I go in for March 2012 for robotics? Because I want to operate till I am attaining an age of 88 also without my tremors. And I am able to see the three-dimensional view, and I am able to dissect the tissues precisely. I will have less blood loss for the patient, and ultimately the patient will have less of post-operative morbidity. So that is the important aim. And again, dogmatically, data-wise, it has been seen that facial closure, once we study, in robotic cases, they have been able to be successfully doing the facial closure in 90% of the cases, vis-a-vis in laparoscopy, they are able to do only in 50% of the cases. And then, in robotics, we don't have to put in the DAX. We can put the sutures anywhere and everywhere. So it becomes so simple, as if you are sitting inside the abdominal cavity and doing the suturing. And that is the biggest advantage. And if one has to go in, yes, I would say, learn laparoscopy well, learn ETAP TAR well, go in for robotic also, and then do the TAR also. In this kind of lot of studies are there. I would not go into the details of these studies, but I would definitely say that lot of studies are there in which if there are complex hernias, if there are incisional hernias, if there are more than 10 centimeters defect are there, or there is a tension on the posterior layer, narrow retrorectus space, then TAR is definitely is the answer. And one has to make sure there will be some challenges when we are going in that safar mein nikle ho, dhoop to hogi hi. So when we are going in for that kind of surgery, definitely there will be challenges. But if you are not able to do the TAR, or if you have learned yourself, then you can go in for modified, Madrid modified.
You have to sum it up.
Sure.
Yeah.
So my answer is length of stay is definitely less in robotic surgery as compared to even open surgery, and wound morbidity is also less. So carry on learning, unlearning and relearning, and then only we will be able to give the best. For especially, please, for God's sake, do not become the laggard. If you become the laggard and you are not an early adopter or a majority, then you will not be able to do the best. And in the end, I would definitely sum up by saying, a fool with a tool is still a fool. So you have to carry on unlearning, and you have to decide it today. You want to become the old pro like us, the open surgeons, or you want to become the modern pro like laparoscopic surgeons, or the ultra modern of AIIMS who are here learning, and you want, so you have to decide on your own, you want to become a ultra modern robotic surgeon or a laparoscopic surgeon. Thank you very much. Thanks a lot for your kind attention.